Good afternoon. The title of my topic today is Torque Your Friend. This was a talk that was given at the Circle of Excellence Conference in Chicago, Illinois in September of 2015. Is Torque your friend? My name is Jeffrey Miller. I graduated from Towson University, did my dental school education at University of Maryland, got my certificate in orthodontics at SUNY Buffalo, my board certification in 1991, and I've been in private practice in the Baltimore, Maryland area for a little over 31 years. Then I can tell you that I've given similar talks to this, and that what you think of the talk today will largely depend on where you are on the expansion maintaining arch width spectrum. If you're expansionist, you may not agree with what I have to say. If you're more towards the extraction or maintaining the arch width, you're probably going to strongly agree with what I have to say. But I need to disclose to you that most of what I have to say is really nothing more than observations. We don't know the clinical significance of what we're seeing using cone beam CT to a large extent. You can make assumptions, but as far as changing the way you clinically treat patients based on the information in this talk, I think is not appropriate at this time. These are observations, and it's going to take a little while before all the research is in to really make good clinical sound decisions from the information we see in cone beam. We're starting to hear different terms creep up in the orthodontic arena. Dr. Vaden uses the term dental dimension. Dr. Nelson uses the term housing. We've been using boundaries. They all actually mean the same thing. They're all describing the bony limitations to orthodontic movement that we can now see on an individual tooth per tooth basis using cone beam CT. If you take a look on the left of the screen, you see this is a reconstructed cephalometric x-ray from a cone beam CT. All these images are from the same cone beam CT. You see from a cephalometric x-ray, we measure torque based on a composite view of the lower incisors. With cone beam CT, you can look at individual teeth and the bony structures that support those teeth. When we talk about torque, we're really talking about where is the position that tooth should be in based on statistical norms, which then relates to where that tooth should be in the bony housing that will give it the most or the best chance of long-term health. But these are based on cephalometric measurements, which may not be accurate. When you take a cone beam and you look at individual teeth, you can see the limitations or the boundaries to orthodontic tooth movement. You look at torque. We are using standard torques from standard prescription brackets. Well, that's assuming that the bony housing or the boundaries for that tooth or the alveolar process corresponds with the standard torque of the bracket. That's not necessarily always true. And I think there's an argument that says, custom brackets with custom torque that can be adjusted to what we're seeing in the alveolar process, or what we're seeing using cone beam CT when we can look at individual teeth. I think there's a good argument that says try to keep the tooth in the housing with proper torques that relate to the underlying bone anatomy, and I'll go over that in a little bit. This case came in for consultation. It's a Brody bite on the lower right side. You see the lower arch is collapsed. Now normally you would just put some brackets on it and attempt to get vertical stops on that right lateral segment. However, when you take a cone beam CT, you see there are boundary limitations to the expansion of the lower right segment. Now, that doesn't mean you don't attempt to correct it. Everybody knows that these are tough to malocclusions to correct, if they're correctable at all. But at least from looking at the cone beam, expanding that lower right lateral segment out would in itself create planned dehiscence of the roots of those bicuspids. Here I flip the cone beam CT so you can kind of line it up with the photograph. Now, knowing that correcting the crossbite is going to create dehiscence of those roots, what do? Well, in my opinion, the current position of the teeth aren't doing that patient any good. And correcting the crossbite, if it's possible, will give the patient a better bite. Even though you know you're going to dehiss, you're still, in my opinion, better off correcting it, because the dehiscence in itself does not necessarily mean that the patient's going to experience tissue stripping immediately. And even if they do get the tissue stripping, that patient's probably better off at least with having some kind of vertical bite stops versus that Brody bite, which will eventually lead to tooth loss. This is what I believe happens when we move teeth through the boundaries or through the limitations of the housing. The top represents the coronal view, the middle represents the sagittal view, and of course the bottom represents the axial view. Well, as we move a tooth through the bony limitations of the housing, you can see that you get a dehiscence along the leading edge of the root of the tooth. Now, that would not be something that you could see from the coronal view. But from the sagittal view, the tooth goes through the boundary, and then you get an adaptive resorption of the bone on the lingual surface of that incisor. There's a tooth-dependent bone morphology that seems to occur, especially in the lower arch. For example, if you extract a tooth, you get resorption of the alveolar process. Well, if you move the tooth through the limit of the bony housing, you get adaptive resorption of the bone on the lingual. So the tooth still appears to be centered within the alveolar process. But actually all you did was you perforated through the facial cortical plate and you got adaptive resorption on the lingual. If you look at it from the axial view, the same thing occurs. You get the dehiscence on the leading edge of the root of the tooth. You do get interseptal bone along the sides, and I believe that this interseptal bone change is responsible for keeping us in business as orthodontists. And then you get an adaptive resorption of the lingual bone. Now, sometimes you hear reported in literature that there's a flexure or a bending of the alveolar process as the lower incisors move. Well, that's based on what's being observed on a cephalometric x-ray. Once you start looking at individual teeth using cone beam CT, I think you'll find that that flexure or bending or alveolar dental change is really just an artifact of the two-dimensional cephalometric x-ray. Here's a lower incisor. You can see that this was excessive class 2 elastic wear. The tooth was pushed through the limit of the bony housing, and then you start to get the adaptive resorption of the lingual bone. You can see kind of in the diagram what's happening. From a cephalometric x-ray, it would appear that you get flexure or bending of the alveolar process, which really didn't occur. When we talk about retraction of incisors, and for example in a class 2 case where we're retracting the incisor, I believe that those teeth fare much better when they're retracted and intruded at the same time, because when you're retracted and retruded, you're going into a thicker area of alveolar housing, versus a patient perhaps with an open bite where they're being retracted and extruded. The tooth is being retract it into an area of thinner bony housing. You're more likely to have dehiscence and fenestrations in this case where you're extruding. This is a slide I got from Gerald Nelson. This was a 19-year-old female patient that was tragically killed. These are autopsy results. You can see here this patient was they were trying to close a space from a missing lower left second bicuspid. You can see that they pulled the incisors through the limit of the bony housing and created dehiscence. Now, unfortunately, I didn't see anything in the article where they showed the soft tissue, but my guess would be there are probably no clinical soft tissue deficiencies initially with a case like this. You know, what happens later on is still remains to be determined. This is an adult patient. We treated her by extracting 2 upper bicuspids, and we were closing the lower space from the missing second bis. You can see that as we retract those upper incisors, we're starting to get dehiscence along the lingual leading edge of the tooth. You can dehisce through the lingual cortical plate just as easily as the facial cortical plate, although as orthodontists, it's nothing that we could see on a cephalometric x-ray, and I'm not sure we're really, up till recently, cognizant of perforating through the lingual cortical plate. If you take a look, here is the cone beam of the upper central incisor versus the reconstructed cephalometric x-ray. There's no indication on the cephalometric x-ray of where that tooth is relative to the lingual or palatal cortical plate. So what do you do in a case like this? This is an African American patient with bimaxillary protrusion. Her chief complaint is the precumbency of the incisors. In cases like this, traditionally they're treated with extraction of 4 bicuspids and the retraction of the 4 incisors. Well, there's no bony housing to retract these teeth. There's not an adequate amount of alveolar width to properly retract and torque those teeth. So you know going into a case like this that there's going to be dehiscence and fenestration. Also, you know, I'm not sure of the stability of a case like this long term. Now, I pulled this case, this is not my case, I pulled this case off of the internet. This was a case that was treated non-extraction with a technique that claims that they developed the arch in the bone and the teeth move together because of the specialized bracket they used, or the wires. Well, I think if you took a look at a cone beam of this tooth, you can see all the root eminence of these incisors, that you would find that there's quite a bit of dehiscence and fenestration associated with that case. Now, that's why it's important. Now, this is a different case, this is a different cone beam, but that's why it's important to look at all 3 views to determine the bony support for an individual incisor. If you look at the axial view here, you can see there's some dehiscence on the lingual, but it doesn't look that bad. But you look at the sagittal, clearly that tooth is not, the torque on that tooth is not aligned with the bony anatomy. You know, there's a wise man once told me that cone beam CT doesn't lie, but liars use cone beam CT. You can make these things really look however you want by taking slices at different angles and thickening the focal trough. You can make it look like there's bone where there's no bone. You can make a dehiscence disappear. So you got to be really careful, and that's why it's important to always look at these things perpendicular or parallel to the long or facial axis of the tooth. We always take the slices when these on my slides. The slice is always going to be taken halfway down the root, and it's always going to be parallel, perpendicular to the long axis of the root. And that's why you can get consistent, comparable images. So Um, it also is not a static evaluation. You're slicing through these things. You're going up and down the length of the root from all three planes of space. You're not just looking at it and taking one image, and that's how you make your diagnosis. These things are made by slicing through the length of the root and looking for defects or whatever. This is a case that came in. A patient was wearing, it was a transfer case, and the orthodontist was trying to correct the class 2 with class 2 only with class 2 elastics. That's how he was trying to get the correction. I took a cone beam on this patient, and here's what his incisors look like. Now, would you continue wearing class 2 elastics here? Or would you put a rectangular wire in to try to torque the roots of these teeth? Well, if you put a rectangular wire here, the torque on this tooth is going to give you labial root torque, which is going to even take the root of the tooth further outside of the housing. Okay, now you just lost the labial cortical plate along the leading edge of the root, and now you're going to put a torquing wire in there so that clinically the incisor looks better. But now there's less resistance because you've lost some of the cortical plate for that root to come forward. But it rotates around the bracket. So are you making that, putting that tooth in a worse position to get a better clinical appearance? I don't have the answer to that. This is the first case. This is a 29-year-old male. He's got lingually locked incisors. He's class 1 on the left, class 2 on the right, and he's got a bone discrepancy. Here's his pre-treatment cone beam CT. If you look, the upper right lateral incisor, you see how the bone dips in to correspond with the lingual position of that upper right lateral incisor. That's typical. This is a tooth-dependent bone morphology. You would not expect to see a huge plethora of bone on the facial surface of this tooth on an adult when the tooth is in a lingual position. I took his case, and what I did is I uploaded to Ormetrics to simulate different treatment scenarios, and I simulated round tripping the tooth. That would be similar to just taking these teeth. I ended up extracting a first buy here to get this cuspid into class 1. But if you could imagine, one way of doing this is just to stick a nitinol wire in there and expanding everything out to get alignment and then close the space. Well, that's probably not the best thing, because if you round trip these teeth, you're going to create further dehiscence or fenestration within the anterior region. It's unavoidable. There's just not enough bone there. Now, what happens when you retract the teeth? Does the bone come back? I don't think anyone really knows yet. So here's what it will look like from the sagittal view. Now, what I did was I didn't touch these brackets for almost 9 months. I retracted the cuspid back to class 1, and then I attached braces brackets to the central and lateral. But if you can avoid round tripping, sometimes it's impossible to avoid, but if you can avoid it, why not avoid it? You're safer. This is a progress cone beam taken at 9 months. You can see there's the lateral incisor. It's being tipped forward, so it perforated a little bit through the lingual. Actually, it's 11 months, I'm sorry. It's 11 months. You can see the torque looks better. But, you know, you can see what you would expect to happen pretty much happened. The tooth came forward and perforated through the facial cortical plate. Here he is finished. I apologize for the alginate that's left on his teeth. And there's his cone beam, finished cone beam. And you could see that we have a dehiscence now associated with the facial root, the leading edge of that tooth. The torque is excellent, and I'm not sure where else you're going to put that tooth, but I think just it's a consequence of what we do, and I don't believe it's going to be a clinical problem. But it's nice to be able to at least inform the patient. Now that upper right lateral incisor still has about 84% total root bone coverage. It started with a 92%, so that's not too bad. And here is the images from start to finish. And pretty much what you would expect to happen happened. And here is what the simulated treatment from the Ormetrics original cone beam CT. You could see the root exposure here. And here is the actual 3D reconstruction using cone beam CT, and although these are not diagnostic, you can see that there is clearly root perforation there, or dehiscence. Next case is another 31-year-old adult male. He came in missing both lower central incisors, and he had a history of trauma to the upper right central incisor. So that time we took pan and ceph, and you can see he had a root canal. And in this case, I round tripped the upper incisors because I want to make sure that the upper right central incisor was not ankylosed before I extracted the upper first bicuspid, which was our treatment plan. He was already missing 2 lower incisors, so our treatment plan was to do aggressive IPR on the lower and extract 2 upper first bicuspids. Here's what cone beam, original cone beam looked like. Now, here I took the cone beam after we placed the brackets. After we did the treatment plan, then I wanted to make sure there was enough bone to round trip these teeth without doing too much damage. And here is what he looks like 4 or 5 months later. You can see the upper teeth are aligned, but they're procumbent. The torque isn't great. Now at this point, I sent him to have the 2 upper first bice removed. However, he decided he didn't want to do that. He was kind of happy with the way his teeth looked, so he said, "I don't want to have the teeth removed." I took a progress cone beam, and the incisors were actually pretty well positioned within the alveolar housing. So I told him, "Okay, it's not ideal, but we'll do it. You're the boss." And we continued to finish up his lower arch. Well, we put a rectangular torquing wire in the upper arch because we were going through the wire sequence. And this is what he looked like a little over a year later. We got everything aligned, and the torque certainly looks better on the upper incisors. Look at the tissue there. You started to get tissue stripping. Here's what he looks like, and here's his cone beam. Now the torque on that incisor looks great, but it doesn't align with the bony housing of the upper alveolar bone. So just because clinically the torque looks better doesn't mean the tooth is in a better position. At that point, I really sat down with him and I asked him why he didn't want to have the teeth extracted, and that we have no choice now because the tooth is in a bad position. And I probably should have asked him earlier, but the reason he didn't want the tooth extracted was because he saw a friend of his in a grocery store, and she had holes in her teeth, as he said, and he didn't want the same thing. So I explained to him that the space is closed. So he got the teeth out. Here's the sequence. This is the original. This is after round tripping. This is after flaring out, and then this is after a torquing wire. You can see here. We're starting to retract. This is a few months later. we're closing all the spaces, getting the teeth in a better position. And I can tell you that this tissue stripping did not disappear. Once I finish the case, I'll wait a few months and then take a cone beam and see really what happened with the bone around those incisors. But he looks better, and I'm sure that these are much more solid bone than where he was before. Thanks for listening. Any questions or comments, you can always email at ortho606@gmail.com. Thank you so much.